Hi, my name is Dr. Brian Vu. I am a PGY4 in the Obstetrics and Gynecology Residency at St. Joseph Mercy, Oakland. Today I will be presenting my research on complications related to intravenous fluid management in hypertensive disorders of pregnancy. The objective of this research project was to determine if intravenous fluid management contributes to complications including pulmonary edema and postpartum readmissions in patients with hypertensive disorders of pregnancy admitted to the labor and delivery unit. Hypertensive disorders of pregnancy are some of the leading causes of maternal and perinatal mortality worldwide. These disorders include chronic hypertension, gestational hypertension, preeclampsia, and preeclampsia with severe features. There has been a 25% increase in the rate of preeclampsia in the United States between 1987 and 2004. Although maternal mortality is much lower in high-income countries, 16% of maternal deaths can be attributed to hypertensive disorders. The most common causes of death in women with preeclampsia include intracranial hemorrhage, pulmonary edema, respiratory failure, cardiac arrest, and acute renal failure. Prior studies have shown that of the causes listed, pulmonary edema is a complication with which has a possible iatrogenic cause. Acute pulmonary edema occurs in less than 0.08% of pregnancies. While most of the cases are related to pre-existing cardiac disease or tocolytic therapy in pregnancy, a large number of cases were attributed to preeclampsia or volume overload. The research design was a retrospective study with 83 patients. The study period was between February 2020 to November 2020. This was a retrospective study looking at patients admitted to the labor and delivery unit with a hypertensive disorder of pregnancy. Each medical record was reviewed by one individual to limit potential bias. Institutional Review Board approval was obtained prior to data review. The total amount of intravenous fluids given during the patient's antepartum, intrapartum, and immediate postpartum period were recorded for patients with a diagnosis of a hypertensive disorder of pregnancy in accordance with the American College of Obstetrics and Gynecology's practice bulletin on gestational hypertension and preeclampsia. A total of 83 women were identified with a hypertensive disorder of pregnancy at St. Joseph Mercy, Oakland from February 2020 through November 2020 using data extracted from Epic electronic medical records. There was only one patient identified that developed pulmonary edema in the immediate postpartum period. Due to the limited number of patients, the statistical significance in the amount of intravenous fluids that the patient who developed pulmonary edema received compared to patients who did not develop pulmonary edema could not be analyzed. There was no statistically significant difference in patients that had postpartum readmissions and the amount of intravenous fluids that they received during their admission for delivery. Table 1 shows the breakdown of hypertensive disorders of pregnancy that the women developed in this study. Table 2 shows the total amount of IV fluids as well as the duration of IV fluids that the patients in this study received. The mean duration of IV fluids was 2,031 minutes, and the mean amount of fluids that patients received was 4,596 milliliters. Again, due to the limited number of patients, the statistical significance in the amount and duration of fluids that the patient who developed pulmonary edema compared to those that didn't develop pulmonary edema could not be analyzed. However, the amount of fluid that the patient that developed pulmonary edema received was 4,090 milliliters, and the duration was 2,072 minutes. This was comparable to the other patients who did not develop pulmonary edema. Another complication in this study was looking at whether IV fluid management would increase the risk of postpartum readmissions. Looking at this table, the p-values are greater than 0.05, showing that there was no statistical significance in the difference in the amount of fluids that the patients who were readmitted compared to those who were not readmitted. The one patient that developed pulmonary edema in this study had a poor obstetrical history, including history of preeclampsia, history of placental abruption, history of 2 prior cesarean sections, history of preterm deliveries, and a history of pulmonary edema in a prior pregnancy. Although this patient received a slightly longer duration of IV fluids, the overall amount of IV fluids received was less compared to the women who did not develop pulmonary edema. This was consistent with the literature in that preeclampsia is an attributable cause for developing pulmonary edema. The patient developed pulmonary edema in the immediate postpartum period while on magnesium sulfate for preeclampsia with severe features for seizure prophylaxis. There was a comparable duration, amount, and type of IV fluid that the patient received compared to those patients that did not develop pulmonary edema. The total amount of intravenous fluids received during the intrapartum and immediate postpartum period did not increase the risk of developing pulmonary edema or postpartum readmissions. Although there was no statistical significance found with IV fluid management and the development of pulmonary edema, caution should be used in the amount of IV fluids patients with a hypertensive disorder of pregnancy receive.